Dr. Smirnov, what is the difference between eczema and psoriasis?
So psoriasis and eczema are different in many ways. What I usually explain to patients is that when you first present with psoriasis or eczema, they can look really super similar. And in the very beginning, this may not be something you're used to hearing from a dermatologist, but sometimes the differences don't matter as much really early on. And that's because when we're using topical medications only, a lot of the topical steroids target the inflammation, not necessarily a specific inflammatory pathway. Now, when you get further along in the disease, you can have a lot of differences. One being psoriasis tends to like extensor surfaces. And by that, I mean places like the elbows, the knees, really loves the back of the scalp. I think about the conchal bowl or the inner ear, the posterior auricular folds or behind the ears and the scalp. Eczema really likes some of the flexor surfaces. So it really likes the antecubital fossa, the popliteal fossa, so I call those the elbow pits and the knee pits. And then it really likes the trunk bathing suit distribution as well. We could have some eczema on the face. It's also really common to get eczema-like reactions on places like eyelids, around the mouth, and on the hands. Now, like I said, sometimes in the very beginning of the disease, we treat them kind of interchangeably. But as the disease progresses, it's really important to differentiate because they work on two very different inflammatory pathways. So the way we diagnose psoriasis is generally clinical, especially in the early stages. We look for it in the prototypical areas that we expect it, meaning the most common areas like the elbows, the knees, the scalp. We also are looking for it to have the clinical appearance that we really expect, which is pink or red. In people of color, it can be a little bit more dark, a little violaceous or a little purple. It usually has quite a silvery scale, so a thick silvery scale. Now that's true of psoriasis located on the elbows, the knees, and the scalp, but sometimes not true in what we call inverse psoriasis, which is psoriasis that can affect the folds of the skin. So think about the groin, under the breasts, and the underarms. We also, when we get further along in the disease process, we like to differentiate it by taking a biopsy. A biopsy of psoriasis tends to show us thickening of the skin, extra scale, dilated blood vessels that are towards the surface of the epidermis. Those characteristic changes tell us that the disease is psoriasis and not just eczema.
So when in life do patients usually get psoriasis?
Usually in two phases of your life. So it can happen, I think, about roughly 18 to 25. And then there's a second phase that's very common for it to break out when I think like 45 to 65. So a little bit younger and a little bit older. When you break out with psoriasis for the first time, we consider you to have psoriasis lifelong. So you just have psoriasis. It can go quiet, meaning quiescent. It can go away for long swaths of time, but you still have the underlying disease state, psoriasis, in our opinion. So if you were diagnosed with psoriasis at 18, for example, we can use many different treatment options to treat it. And even if it goes away and it's no longer troubling you, you still have that predisposition to breaking out in psoriasis. So we would still consider you having psoriasis, even if you don't have any active plaques or rashes on your body. Think of it as a lifelong disease that we can treat, and we can usually get into remission, but we never consider it totally gone. There are a few lifestyle factors that can help mitigate breaking out in psoriasis or even improve your psoriasis. And some of this is data-driven, meaning we have evidence that shows that it works, and some of this is still kind of in the realm of being discovered by current scientific methods and models. And so when we think about people with psoriasis, it tends to be people who have obesity. Smokers can have it a little bit worse. And also a poor diet can lead to it. So on the flip side of that, if you have psoriasis and you're trying to control it, one of the things that you can do is dietary modification. There has been some data, Mediterranean diet can be helpful in the treatment of psoriasis. There are also indicators that things like intermittent fasting, other forms of dietary restriction can actually be really helpful in decreasing body-wide inflammation and resolving psoriasis. We also know that metabolic syndrome and psoriasis are linked. Some of the really new popular medications like GLP-1 medications have been known to, when we treat people with metabolic syndrome that happen to have psoriasis, they tend to clear for their psoriasis while they're only being treated with GLP-1s. And there are companies out there right now who are launching the use of two medications, a psoriasis medication and a GLP-1 in consort, to get even better control. So yes, absolutely, dietary modification can have a really big role in psoriasis. Not just that, we find that people with psoriasis, if they are better able to control their stress levels, do very, very well. I think of psoriasis as one of the very stress-responsive dermatoses. And so when you're gearing up for a big presentation, your psoriasis may have been quiet for weeks or years, and you may have a little itching behind your ears or a little flaking on your scalp line because your psoriasis can be responsive to your internal stress. Psoriasis can occasionally be helped by exercise, but I don't think of it as a direct correlation that if you exercise more, your psoriasis gets better. Instead, I think of it as a more holistic response to when we exercise more, our stress levels decrease, our overall health increases, and our propensity toward metabolic syndrome or obesity decreases as well, thus reducing all of these associated factors that make our psoriasis more aggressive, more difficult to treat.
And how do you treat psoriasis?
A first-line therapy for psoriasis for someone facing a new diagnosis would most likely be barrier repair. And by that, I mean using emollients, moisturizers, lotions, creams that are specifically targeted towards psoriasis to kind of help. There are also lots of topical creams and washes that have a little bit of salicylic acid. That is meant to target some of the thickening and the scale associated with psoriasis, to get rid of that scale, to flatten out the plaques that develop when we get psoriasis. For scalp psoriasis, there are actually quite a few over-the-counter options that work quite well. Those include Nizoral, that's an anti-dandruff shampoo. There's also T-Sal, which is a salicylic acid-based shampoo that you can use for the scalp, and T-Gel, which is a tar gel that works quite well. Those three help with, flake reduction, with some of the inflammation, and a lot of times help mitigate symptoms. In more advanced cases, sometimes we do need topical steroids or prescription non-steroidal products. And in even more advanced cases, we can escalate care to oral pills or biologic injection. Psoriasis can affect some sites that are just a little bit more difficult and that we want to treat with a little bit more care. Those sites tend to be the scalp. So the scalp can get so itchy that it actually becomes uncomfortable, that it can be difficult to sleep, or you can start to lose hair when you have psoriasis of the scalp that's untreated. In those patients, even though a large percentage of their body isn't covered in psoriasis, sometimes we have to escalate care just because their quality of life takes a dive when their psoriasis is flaring on their scalp. Another area where psoriasis can be somewhat invisible but still extremely symptomatic is the groin, the buttocks, the folds of the underarms, and under the breasts. We call that inverse psoriasis. I think of it as kind of a hidden disease because it doesn't have the same scale that you expect in normal psoriasis, but it can make us really embarrassed. It can make you self-conscious. For those sites, we tend to use non-steroidal medications. Some of the new novel therapeutics that can be used topically are very, very safe and don't run the risk of thinning skin the way some of the topical corticosteroids do. So we use very specific targeted medication. If you have these recurrent rashes in these locations, don't forget to check in with your board-certified dermatologist. There's nothing you can't talk to us about, and there's nothing we haven't seen. So we can help you get relief if you need it.
How does Malassezia furfur relate to psoriasis?
Malassezia furfur is a yeast that grows naturally on all of our skin, but it can actually exacerbate psoriasis quite a bit. It's quite common as a player in multiple skin conditions. That includes psoriasis, seborrheic dermatitis, which we kind of think of on the spectrum of psoriasis, pityrosporum folliculitis, which is basically an infection of the hair follicle that is caused by that yeast. And then the last one that we think about is tinea versicolor. So when you go to the pool or the beach and you see people with different colored patches on their body, that's the yeast causing it. A lot of times It doesn't drive psoriasis as a primary method, but as a secondary way of exacerbating it. So I think of it as worsening the environment for psoriasis-prone skin. So when we prescribe things like ketoconazole shampoo or antifungal treatments, that's really to target decreasing the amount of malassezia on the body so that you are less prone to outbreaks. The areas that are really prone to malassezia or this yeast are in the seborrheic distribution, which we think of kind of as the mid-thighs up. So basically anything from the mid-thighs up has a lot of oil production and can get very oily, especially during the hot months. And in scalp psoriasis, we see a lot of exacerbation on the scalp. So meaning that you get a lot worse on the scalp in the oily areas behind the ears. The other places we see it a lot are kind of along the eyebrows, in the nasolabial folds, a little bit in the beard in men, and it can be behind the ears. We also can get a little bit in the conchoid bowl, which is the kind of inner part of the ear, and all throughout the scalp. Some in the chest and some in the upper back is pretty common as well. So a lot of times we think of this as not a primary driver, but an exacerbator of psoriasis.